Good day. I'm Dan Jones. I'm chairman of the writing committee for the American Heart Association and American College of Cardiology Guideline on Blood Pressure Management in 2025. Pleased to be with you today here along with my vice chairs, Dr. Keith Ferdinand and Dr. Sandra Taylor. I'm an internist from the University of Mississippi Medical Center, and now I'll turn to Dr. Taylor and Dr. Ferdinand to introduce themselves.
I'm Dr. Keith C. Ferdinand. I'm a clinical cardiologist and the Gerald S. Berenson Endowed Chair in Preventative Cardiology at the Tulane University School of Medicine in New Orleans, Louisiana.
I'm Sandra Taylor. I'm a nephrologist and hypertension specialist at the Mayo Clinic in Rochester, Minnesota.
All right, thank you guys, and thank you for the audience today. We're here just to give you a little bit of a tidbit about the new blood pressure guideline. I think we all know that blood pressure is the most common modifiable risk factor for cardiovascular disease and stroke, and happy to have new guidelines to help clinicians understand what they need to do for their patients. The guidelines are important. We hope you'll find these useful for you in your clinical practice. Now, Dr. Ferdinand is going to take us for the next step, and then Dr. Taylor, and then I'll close this out. Dr. Ferdinand?
Thank you, Dan. As you know, guidelines are not laws, but it helps us as clinicians to make the best care available for our patients. The last guideline of the AHA-ACC Multi-Society High Blood Pressure Guideline was in 2017, so a lot has changed. Clinicians need to know how low they should go in terms of targeting blood pressure. Especially, there was a lot of controversy at that time related to blood pressures in persons who have diabetes and older patients. You know, at one time when I practiced, we used to say that your systolic blood pressure was your age plus 100. Sounds crazy, but that's what we thought. And we now have new information, so the guidelines should reflect that. There's also increasing data and controversy about how to use the new Prevent Risk Calculator. And we've tried to indicate that even in those persons who are at lower risk, after 3 to 6 months of therapeutic lifestyle changes, there may be beneficial approaches, including pharmacotherapy. Finally, in more complex patients, including those with resistant hypertension and patients of various degrees of target organ damage, the science has continued to evolve as to how to address those patients.
There are many changes to the guideline, more than I can tell you about in a short conversation, and I would encourage people to read through the guideline. It's set up in discrete sections so that it's very easy to absorb. For example, while we recommend a blood pressure target of less than 130 systolic and 80 millimeters mercury diastolic, we added a caveat encouraging clinicians to get blood pressure down in those who are able to less than 120 systolic. So that would be an added effort to better control. We're recommending a lower sodium intake in general, ideally down to no more than 1,500 milligrams of sodium a day. And we're recommending limits on alcohol intake, minimum limits, but encouraging abstinence, which would be optimal for health. As Keith mentioned, we've gone to a different risk calculator using prevent rather than the pooled cohorts equations because there's really more data, and so it's a stronger tool for estimating cardiovascular disease risk. We're encouraging potassium salt substitutes based on trial data showing a benefit, but with appropriate caution for those who are on potassium elevating medications or have kidney disease. For patients with diabetes, we're very comfortable with the 130/80 target for blood pressure lowering, and also encouraging that lower systolic target when feasible. And for those patients with diabetes, we're encouraging use of ACE inhibitors or angiotensin receptor blockers, particularly in those who have some component of kidney disease. We're encouraging weight loss approaches for patients with obesity, including the use of GLP-1 receptor agonists and even bariatric surgery for those with more severe obesity, as they have been demonstrated now to also help with lowering blood pressure. For patients with chronic kidney disease, we're encouraging the use of an ACE inhibitor or an angiotensin receptor blocker for those with chronic kidney disease, whether they have diabetes or not, and for those with really any degree of albuminuria. And then for patients who have severe hypertension, but no active evolving target organ damage, we're encouraging that this be addressed out of the hospital and without acute blood pressure lowering, which has been shown to be less beneficial than changing the usual daily regimen. And there are many more items that I can't summarize here. So again, I would encourage you to look at the guideline closely.
Sandra, if I could add, some patients may not need two medications. Those would be persons who are at lower risk. We calculate with the prevent risk calculator of less than 7.5 over 10 years. And in that particular case, of course, you want to give a trial of lifestyle modification. But we found that the drug therapy, which is most effective as a first step, would it be thiazide type diuretics, long acting dihydropyridine calcium channel blockers, or even an ACE or an ARB. And we really don't make a big difference between ACE inhibitors or ARBs unless the person would have other complicating factors. Both are effective as a first step in many of these patients. Now, where there may be some new data is that in patients who have stage 2 hypertension, that's a systolic blood pressure of 140 or greater or a diastolic of 90 or greater, in those patients, they do need two initial agents of different classes. And we suggest that if ideally you can do it, start with a single pill combination. It's recommended because that may increase blood pressure control and it may also increase adherence. You know, we were always concerned that in our society, the degree of blood pressure control is not equal across all populations. And we know non Hispanic Black populations tended to have higher blood pressures, more complicated blood pressures, but we don't make a recommendation, especially for initial therapy based on self identified race. We think it's more important to choose from those recommended classes of agents, and regardless of race, we now know that patients may respond. And once you get patients who have stage 2 blood pressure, unless there are compelling indications, the various combinations, for instance, a thiazide-like diuretic, an ACE inhibitor, thiazide-like diuretic, ARB, long-acting calcium channel blocker, ACE inhibitor, long-acting channel blocker, ARB combination, the patients are going to respond regardless of self-identified race. So we're pretty agnostic about what approach to take in those situations, and we suggest that patients be treated with the best medicine possible, regardless of self-identified race.
Yes, and I also wanted to point out that we don't handle elderly as a separate category this time. So age is just a number, and there is no age cutoff at which you would not aim for lower blood pressure. We would recommend the same targets for independently living elderly persons as for younger persons, as long as they're able to tolerate it. And I wanted to point out, and didn't in the first list of items, that we're also recommending this tighter blood pressure control to prevent dementia and mild cognitive impairment.
Boy, I think that's a really big one, Sandra. We know a lot of older persons will say that they're having problems with memory or cognitive function due to age, but in many cases, it may actually be small vessel disease from the ravages of uncontrolled hypertension. A huge study, over 33,000 patients out of China, demonstrated that tighter blood pressure control actually improves cognitive function and decreases the incidence of dementia. So I think that's a big step forward.
Well, Sandra and Keith, thank you for your wisdom. Thank you for sharing it with this audience today. I hope these tidbits from the 2025 blood pressure guideline will entice all of our listeners to read comprehensively the new 2025 blood pressure guideline. This guideline is a work of 28 committee members, all clinicians, written by clinicians and for clinicians for the benefit of our patients. So we hope that this little video has been useful to you, but we also hope that the comprehensive reading of our guideline will be of use to you and to your patients. I thank all of the committee members who have been involved, and especially my two vice chairs, Dr. Ferdinand and Dr. Taylor. So thank you and good day and good blood pressure control.